Yes, 30 seconds, okay. Warm salutations from wherever you are catching this particular episode of The Big Picture. My name is Moige William and welcome to another episode of The Big Picture. Quite always fun to have you and for your invaluable company. Well, a lot has been happening, a lot is happening today, and I am not alone. Together with me is Justine Wanda to steer this conversation. Justine,
yes.
Good evening.
Good evening.
Good morning. Good afternoon.
Good night.
Glad to see you.
Glad to see
Did you survive the week? A lot was taking shape in the country.
I think survive the week is very arbitrary.
Yeah.
As long as we're here and we're still pushing through, I think that's all that matters.
Yeah, because just to bring up to speed our viewers is that currently as we speak, there is an ongoing ruling, the impeachment of Rigathi Gachagua. Yes. He did file a petition in the High Court, so a three-judge bench is currently delivering its ruling. That is Justice Eric Ogola, Justice Anthony Murima, and Justice Freda Mugambi. They're delivering that ruling. Also, how many girls they were arraigned and they have been detained?
Yes.
For 21 days.
I think 9 or
they are 9, yes. 9. This is in relation to Naivasha girls.
Utumishi.
Sorry, not Naivasha girls. Utumishi. Thank you for the correction. And Ebola. Did you see the Cabinet Secretary for Health, Eden Duale?
Me, first of all, let me just self-censor.
Yes.
Because we still have to look into the show and get into the nitty-gritty of this story with the facts intact. So let's not jump the gun to the anger first. Let's just...
And actually, on this particular episode, that is what we're going to be discussing. Matters Ebola, matters, what is happening in Goma, that is Eastern DRC, all the way to Kenya, all the way to the United States. I mean, a lot has been, we are having the president in South Africa, President William Ruto, speaking about matters Ebola. And that is what I want us to discuss on this particular episode. Matters Ebola, matters the United States and Kenya cooperation deal, and what is happening. Do you know there have been 40 outbreaks of Ebola? Did you know that?
I didn't know
since
there
1976.
Were 40 in Kenya or
no, in globally.
40 outbreaks.
40 plus. But don't worry.
One for each decade or is it?
Don't worry. So dear viewer, you can be part of this conversation by sending in your views via all our social media platforms at Africa Uncensored. And if you have any questions or comments, please do not hesitate to share your views and questions and comments. And to discuss this particular topic, we have quite a great panelist. And I will start from my far end on this particular panel. We have Caroline Katindi. Yes. Welcome to the broadcast.
Thank you.
Yes, so Caroline is a bioethicist, a lecturer, and a research ethics reviewer. And also next to her, we have Dr. Nelson Malenya, also a bioethicist. Welcome, Dr.
Thank you very much.
Yes, and joining us remotely or online, we have Melba Katindi, who is an advocate of the High Court. Melba, where are you joining us from?
I don't say good evening, good morning. I'm joining us, or all of us, from Nyahururu.
Yeah, what's happening in Nyahururu? How is the weather there?
It's very cold, as you can see. I'm equipped.
Clearly.
Dr. Malenya could share his cup of tea.
Yes.
Coffee.
Justine was organizing some tea for you.
I'm gonna fly a coffee out there for you, but.
All right, ladies and gentlemen, thank you for making time. And I don't want us to have, question answer. Let's have this conversation to the benefit of Mwananchi. A lot has been said so much about Ebola. And citizens are concerned across East Africa, not only here in Kenya alone. But I'll start with you, Dr. Straight to the point. Is the government sincere? There's politics, there's legal issues in this whole Ebola discussion. But what is the government sincere in this talk from a medical perspective?
Okay, that's an interesting question. Is the government sincere from a medical perspective? I think what I can speak of is what I know of Ebola itself. Okay, and you're right by saying that since 1976, we've had 40 plus outbreaks. What I can say is that Ebola is scary, isn't it? So when the government operates how it's operating, I think it's operating out of some sort of urgency. So I will not say whether it's government is sincere or not, but I'll say that it's a situation that needs some urgent attention. Okay, and as we move along, it will be good to demystify Ebola itself and see how it can affect us if it comes onto our soil.
Okay.
Yes.
We will get there. Wakili, legally, is the government of Dr. William Samoei Ruto, cutting through the noise, politics and everything, is the government sincere when it comes to responding to this issue? We have seen a court order halting, the setting up of quarantine isolation centers.
Well, I think my answer would be both. Why both? When we are talking about public health emergency, we're talking about a medical issue. So, of course, what we are seeing initially is the government trying to respond from a medical perspective. So, medically, we are seeing responses that appear to be based on the information we have scientifically about the Ebola and the response that is needed in terms of just preparing for it and containing it should it get within our borders. But we have to acknowledge that some of the decisions that accompany a medical intervention will border on both political, legal, and ethical decisions. So when we are looking at things such as where do we locate a facility, who can be admitted into that facility, who pays, who can come into our borders, who bears the risk, who finances, who trains, all those then cut across. They go beyond being medical decisions and they become political, legal, and ethical decisions.
All right, we will get to the nitty-gritties. Caroline, do you agree that this is medical, ethical, and yeah, all the names?
Yes, it's cross-cutting. It's cross-cutting. Just to demystify ethics, ethics just is to deal with what is the right thing to do and what is the wrong thing to do. That's what ethics is trying to deal with. So if we can ask the question, is Kenya right to host such a facility? Perhaps we are saying, is it right for Kenya to be prepared for Ebola?
All right, we will get there.
We'll get there.
We will get there.
Yeah.
Okay, now my question to the three of you, just to ask, then what is the reality that Kenyans are facing in relation to, bringing possible Americans who have been exposed to Ebola to be isolated and quarantined here in Kenya and the spread of Ebola? I'll start with you.
You start with me?
Yes.
Not with the medical doctor.
What is the reality Kenyans that are facing or could potentially face in this whole discussion about Ebola?
Okay. I was talking with Nelson earlier, and we don't have our index patient yet. That is, an index patient is a Kenyan who has Ebola. All right? So we don't have one yet. Yet we're discussing bringing in an index patient that is not a Kenyan. So we are bearing the risk on behalf of these people who are coming into Kenya. So this now means then we have to be very clear is what are we going to benefit from it if we are going to bear the risk. And all three of us review the proposals and we do research. And that's the story with research. Always asking, you look at the risk and you look at the benefit. Unfortunately, we are still not very clear on what the benefit would be. And that's what is making us all a little bit nervous. For example, can Justine go to that facility? That's the one question. Can she go? And will she be treated? Will she have to pay for it? Yes. Are they sure that that facility will not allow any Ebola to get out of that facility to the surrounding areas? You know, such things are the things that if a Kenyan would be told, we'd feel a bit more calm. But the fact of the matter is, we have the last 40 years, there have been epidemics of Ebola. They've never really come into Kenya, but we've always been on the verge. We've always been just about to have our index patient, then we don't get.
Okay.
So we really must take advantage of this and become prepared for the day we do have an index patient.
Okay.
Yeah.
Preparedness. Dr. Nelson, away from what Duale is saying, away from what Gachagua is saying, away from what Sifuna is saying, what is the reality for Kenyans? What are they facing?
Okay. Thank you for steering me away from the politics of, because I'm not competent. Now, to look at the reality, we may want to look at a little history. We know that 2014, 2015, somewhere there, in West Africa, we had one of the worst Ebola outbreaks. Yeah. And for various reasons, it really spread, it was really bad, and we can discuss why. But during that time, people may not know that the US got its index case, and then 2 years later, Nigeria also got its index case, all of them connected to West Africa. Why am I saying this? I'm saying this because how an outbreak moves through borders, you don't want it to be out of commission. Okay, in that you did something to make it pass. Like in the US, what happened is that there were two patients, Americans, who were transported from West Africa, that's Liberia, to Atlanta, where there's a CDC center, and there's a very good university there. Emory University is a very good infectious disease center. So when they were transported there, and the public knew, there was an uproar because they felt that now they have imported Ebola into the borders of the US. They were lucky because they contained it. However, a few weeks later, a Liberian who was naturalized in the US traveled back to the US from Liberia. And he was sick, fever, headache, and went to hospital and was given some medication. They did not know it was Ebola. So when he was let to go, his condition got worse. And so he was brought back to the hospital. And at that point is when they discovered that it's Ebola. Unfortunately, he died. But when he died, he had infected 2 other nurses. So when we talk about Ebola crossing countries, being able to manage it is one thing. Bring a disease into your territory is another. Now, in Africa, one case happened. Guess which country? This was Nigeria. There's a gentleman called Patrick Sawyer who was a lawyer, actually. In 2016, he moved from Liberia to Nigeria secretly because he felt that he knew he had Ebola, but he wanted better care. He did not disclose his condition. Unfortunately, he passed away. 20 Nigerians got infected and 8 passed away. So that was the index case in Nigeria. So when you talk about being careful as to how you treat and transport Ebola patients, it can become complicated. Mm-hmm. The populace itself can have a backlash. I guess that's why the Americans don't want to bring any case back into the US.
Okay.
Yes.
We'll get there. We'll get there. You want to jump right in? Okay.
I am very concerned, at least because you've said you do not want to be the one who's commissioning the disease.
Mm-hmm.
Yes.
Which feels like what is happening right here. Which, as bioethicists, you already have ideas of like how that looks like on your end, and you've laid out how that could play out. So that we are currently working with a framework that's part WHO and then part just an agreement that Kenya has directly with the US. Mm-hmm. So what does the US removing themselves from the WHO, how does that put at risk the people who are making healthcare cooperation frameworks with them?
Okay, maybe I can try that. So what the WHO does, it tries to regulate how healthcare is discharged across borders and within countries, and it's trying to standardize that. So when it comes to outbreaks, there are regulations that stipulate that wherever there's an outbreak, especially of a critical disease like Ebola, you need to treat it at location, because transit of patients from one location to the other has a risk of transmission. Okay. Now, granted, you may be seeking better care, but you have to balance the risk and the benefits of what you're doing. So you find that most of the countries which have got endemic diseases, in those countries, you've got specialized centers that treat these people. You talk about malaria. If you think about malaria, most of the specialized centers of treating malaria are in Africa. You may ask why. It's because malaria is endemic in this region, isn't it? And some parts of Asia. Okay, you'll not find that in Europe and in the US. In fact, if you get malaria in the US, you will really struggle, because before they pick it out, they'll have thought of other things. So what WHO does is that whenever there's a condition that is found to occur mostly in a particular area, they set up centers of excellence in those areas. Now, the US having moved out of WHO, it gives the US some freedom to operate outside the regulations of WHO. So that could complicate it, because it will not be kept accountable in the international system of healthcare. So then if they want to transport somebody from Congo to another place, then they'll not have to justify strongly as if they were in the WHO setup. So they have got some freedom to move.
But at what cost? Like the freedom to be able to dictate the healthcare on your own terms makes sense to a level, but healthcare, unlike most of these other issues, it's very critical to different countries. Like, if the resources in the country are better, you probably likely get the attention that you need. But if it's a little less resourced and you have to set it up just to manage the disease, it could actually spiral, because maybe there's not enough people who've been trained, or you don't have enough facilities to work. So again, I just want to get maybe from you, Caroline, like how them being not part of like a larger cooperative framework with the rest of the world puts us at risk.
It does, in a single sentence, and I think Melba also speaks to this from a legal point of view. We have to start by asking ourselves that if Ebola was to break out in our country, what are we ready? That is the question. And what does it mean to be ready? So it seems that because of America has many people in the DRC, they do have people who regularly get Ebola. But to be very truthful, I don't know, maybe somebody else could speak to this, I don't know how many people actually ever in our history of Kenya has been treated for Ebola in Kenya. So we are sort of like a naive population, you understand? Yeah, we don't have many of those Ebola antibodies swimming in our blood, because malaria we have, yellow, all these other things we have. So we are a little bit susceptible from that point of view. So when somebody is flown in with Ebola, if that Ebola escapes the location it has been put into, we shall be in quite a lot of trouble, because we are truly quite naive to the Ebola. So we need to then ask, and Melba alluded to that, is it just now because an American has gotten Ebola that we should care, or should we have long-term Ebola preparedness? And if the Americans are willing to bring a facility here, then can they also make sure that we do have long-term Ebola preparedness to as much as they are able? Because it's not fair for us to be bearing the risk for the region without getting any benefit. So as a sovereign nation, we should be allowed to ask them whether they are acting outside of the framework, that, hey, how are you protecting our citizens? And if our citizens are not going to be protected, then find somewhere else.
Okay, Melba, I just want to loop you in into the conversation. You've had Caroline, you've had Dr. Nelson. You know, they're raising quite pertinent issues, but again, we have seen a court order, and we have seen the United States speaking to this issue, and we have seen the Cabinet Secretary for Health, that is Aden Duale, telling the National Assembly that setting up of these quarantine isolation centers will go on. This is despite a court order. Whose interest is the government of Kenya serving?
Let me start by picking the conversation where Caroline left it, and Malenya also talked about it. Our reality is that we are finding ourselves in a situation where we need international cooperation. We know that outbreaks are local. You have an outbreak which is very local in nature, given that it originates from a particular area. But then, in terms of its consequence, it's not localized. It's regional, it's global. So Kenya does have some moral imperatives, some human rights obligations in terms of just extending some international cooperation. But we have to then ask ourselves, within this cooperation framework, is it lawful? Okay, is that cooperation equitable in terms of how we are approaching it? Are the terms transparent? And that's the reality we find ourselves in. We actually know that there is a risk to the country, but then we are not clear about what cooperation then means for Kenyans. And while I can't speak to what the United States motives are in terms of how they are responding to Ebola and this current outbreak, what I can say with authority from a legal perspective is that every single government, including the government of Kenya, has a legitimate obligation to actually protect its citizens from any public health threat. And that includes using measures and approaches that it deems fit. That's what we call sovereignty and independence of any country. So the more important question for us is not what the US is doing, but then how does that affect Kenyans? And because I've said that every single country has a duty to protect its people, if the US is not going to allow Ebola into its soils, then we must ask ourselves, why then should Kenya be an alternative site for that? And from my opinion, we need the details of this arrangement. And that's what Kenyans have been asking for, and that's what the court case is about. Do we have legitimate justification to be hosting such a facility on behalf of the US? Because we do have an obligation over and above that which is to the globe. We have an obligation to protect our citizens. So we have the right to actually ask, is there a legal basis for such an arrangement?
Okay.
What is Kenya? Yes.
Sorry, go on.
Yes. So people are asking, and this includes what is the subject matter before court. Do we have a justification? What is in this agreement? What is Kenya going to receive? Because we have to talk about reciprocity. If we are going to talk about cooperation, we have to talk about, is there fairness in terms of benefit and sharing in this type of arrangement? So coming to the statement by CS Duale, you've talked to me about the statement and the court cases, and those are separate things. In terms of the statement, from an analysis of what he said, I think he was specifically anchoring his response to the Public Health Act. And under the Public Health Act, the ministry and the government is not required to actually have public participation to establish quarantines and quarantine facilities and isolation facilities. And therefore, consultation is not necessarily mandatory in that context.
Yeah.
But then this is a very narrow approach, because the issue among Kenyans is not whether we should have quarantine and isolation facilities. We need them. The issue is there enough information that has been disclosed to the public about the agreement, about the preparedness, about the nature of threat, and about how Kenya will benefit from this arrangement? And that information has not been provided.
All right. Melba, I believe you are referencing Public Health Act, that is Article 35 and 36, if I'm not wrong. But maybe, I don't know if these are possible answers to what you are raising. We heard the president, that is President William Ruto in South Africa, speaking to this issue, and also the Cabinet Secretary for Health, that is Eden Dwale. Maybe we can take a listen to what they said in relation to Ebola, and then we can quickly react to that before we shift gears into this conversation. Take a listen. All right. As we prepare to bring you that particular video, just in a short while, we will be giving you that particular upsound and voice of the president and Eden Dwale. Are we ready?
The American government has supported us in this Ebola setup infrastructure, health infrastructure, to the tune of 1.8 billion Kenya shillings. And they did make a request to us to, in the process of setting up all the other facilities, to also set up one where they can use in the event that their citizens, their soldiers, some of them in Kenya or from elsewhere, if they are in a situation, then they can use that facility.
But I want you to look at what Dr. Tedros, the DG of WHO, said when he was in Ituri last week, and urged African countries, the regional leaders, not to close borders. Ebola or any other infectious disease does not know a border. It will cross. So how do you contain? We have thousands of Kenyans who are in that place. Do you allow, you're telling me we should allow them to die? You today, if you become sick and you are rushed to a hospital, your family have the right to take you to a better health facility.
The American government has supported us.
Yeah, there is President William Ruto in South Africa saying it will not be proper not to allow Americans to set up a quarantine isolation center here in the country, and also Eden Dwale still reacting on this raging debate of Ebola. But I want us to shift gears, because we have been having this conversation for 20 minutes now, and we have done quite an injustice to our viewers and our listeners, not explaining why this Ebola thing is causing some ripples within the country, within the region, even warranting the concern from the World Health Organization, WHO, the Center for Disease Control, CDC. I mean, why the scare? What is this Ebola thing? Could you guys simplify it for the Mwananchi to understand, and maybe talk of the variants? I know we have had the Sudan Ebola, the Sudan virus. We've had the Ebola virus. Now we have another one which has a name it goes by the name Bundibugyo virus.
You can just call it B.
Yes.
Dr. Nelson, what is this Ebola? Why the scare?
Okay, so I'll try to be as simple as possible.
Please.
It's good to be scared. Let's start from there. It's good to be scared because Ebola is a critical illness. It's a dangerous illness. If it got into our midst without proper care, it can wreak havoc. So what is this Ebola? It's basically a disease that is caused by a virus. Okay, and this virus is transmitted through bodily fluids. Okay, now talk about bodily fluids. Any bodily fluids like tears, saliva, blood. Okay, semen, vaginal fluids, all the body fluids contain the Ebola virus. And it's transmitted primarily from animals to human beings initially. Okay, so we talk about either foot bats or talk about primates, these monkeys or apes. if there are communities which are in contact with these animals, there's a possibility they can contract the virus. Now, it is not affecting those animals as such because over the years they've developed some degree of immunity, but the human being has not. So it's going to affect us. And then once a human being gets it, okay, through the contact for these animals, then you can transmit from human to human through those bodily fluids, including blood. Some people note that Ebola is not airborne like COVID, okay? So does it make it easier? No, it's because the case fatality rate, if you get Ebola, okay, now we're looking at 1976. In 1976, the case fatality rate was about 90%. But right now it's dropping. It's not dropping because the virus has changed, it's because our medical care has improved. Okay, so we now have got medication, this monoclonal antibodies that can treat Ebola, but only for the Zaire strain. As you mentioned, there's Zaire strain, there's Sudan strain, there's this Budibugyo strain. You may wonder, what is that? That's just a region in Uganda, the western part of Uganda. It's a district, okay, called Budibugyo. So they named it according to the district where it was first isolated in 2007.
Yeah, 2007.
Yeah. And you see that region borders Congo, okay? So now where the outbreak is occurring right now in Ituri is across the border, not very far from Budibugyo district in Uganda, okay? So you find that those strains happen now. The beauty is, okay, not the beauty, but the saving grace is that the Zaire strain is the most virulent. Okay, but as you come down, the case fatality rates for Budibugyo is lower. Okay, so that's some kind of saving grace. It doesn't mean that we should put our guards down, because if you get the disease, the care that you can get is either supportive care. Okay, supportive care means that because the virus kills you because it causes destruction of your immune cells. It will dysregulate your immune reaction, okay? And then you'll also have issues with clotting, and your the blood vessels will also have a problem. And then eventually you'll have multiple organ failure. So to be treated, you need supportive care, like in an ICU setting, to support those functions and maintain your blood pressure. Now for the Zaire strain, okay, we have got monoclonal antibodies and also vaccines that you can be given to prevent and to treat. Now, why it's a big deal for Budibugyo is because we don't have a vaccine and we don't have treatment. So we can't let our guards down. That's why we need to take it very seriously.
All right.
Yeah.
Let me loop in, Caroline. You were talking about preparedness. All right. From 1976, we have had this particular Ebola virus. Oh, the Kikuyu in me is doing the thing. Sorry about it. Yes. 40 plus outbreaks we have had, 2014 to 2016, claiming close to 10,000+ deaths. That is in West Africa. 2018 to 2020, DRC 2,000+ deaths. Now I'm just looking data from CDC. Look, this outbreak, it has been in Senegal, Mali, Guinea, Cote d'Ivoire, Liberia, Nigeria, South Sudan, Uganda, DRC, Gabon, Congo. Now we're having the government talking about, flying in people from DRC to Kenya. Is it making sense? Even in as much as we are talking about preparedness, is it making sense? Since 1976, Kenya's never been affected.
Yes. The last epidemic came very close. It actually came to the border, the Busia border. And this is what you must understand about disease. It doesn't have borders. We are concerned about Americans being flown in, but there are other people coming on foot, people who have gone to DRC to look for work, isn't it? Coming by bus. So the fact that we have never had an index patient should not make us feel that we are somehow excluded from getting Ebola. We can get it. The only reason we haven't got it is, even for right now, I can't really tell you, but it just hasn't crossed our borders yet. So the question is, what should we do? How should we prepare ourselves if it crosses the border? Now, because we don't have treatment now for that particular strain, the thing we'd have to be doing is, first of all, find out if you have it, and then do what? Quarantine you. Those are the two things. So that we hope you will survive, but we don't want you to get you to infect another 20 people. And like we were told before, actually, Ebola gets worse. Any epidemic gets worse with the way you react to it. So you had the story of Liberia. They brought the army. They tried to force people to go into quarantine. What did they do? They spread it even worse. So the way we respond to it is very important. And in our country, we do have these things that are called, what are they called? Notifiable. They are things that you're supposed to report if you see certain things. Yes, even in level 1, even in dispensaries, they take note of people coming in with fever, coming in with diarrhea. They take note. And they are supposed to be notifying people, the Ministry of Health, all the time, just to make sure that if it comes, we catch it quickly. That is the way.
But on the other end, deliberately, we are bringing the disease closer to the people.
Deliberately.
Yes, that is deliberately.
So let me ask a question.
Yeah.
I don't know if it's a strange question, and I asked this to you, Justine. I said, let's just say Uncensored Africa, you were to do some show in DRC, and all of you beautiful people went there. And then one of you got Ebola. What would you prefer to happen?
But what we are talking about,
I know,
is the cooperation, health cooperation between Kenya and the United States.
Yes.
How fair are we being to the people of Kenya?
This is thing. So the one I'm talking about preparedness. So the thing is, we just have to become wise at this point. As Ms. Melba said, we must really say, what are we benefiting from carrying this risk? What are we benefiting? Are we going to train anybody? Any health people? Are they going to be trained so they can know what to do? Are we going to have access to the facility? That's the biggest one for me. Are we going to have access to the facility? Because if we're not going to have access to the facility, then it might as well be in any other country other than ours. We really must benefit from having a disease brought into our country when we didn't have it. And this is what I feel we are not being told. What if something goes wrong? Who is going to take responsibility? Is it the American government? Is it the Kenyan government? Who? Is it the chief?
Yeah, good question.
Yes.
And I think Melba should answer that. Because, look, Melba, the Constitution of Kenya is there to protect Kenyans.
Yes.
But is this the case when it comes to this whole debate?
I think when we talk about preparedness, when you want to prepare for anything, you have to anticipate what that would look like in your context. And from what we are hearing, and from the communication that's coming, preparedness is talking about, like the medical side of it again. So my purpose here is to really draw attention to the non-medical nuances that we need to be talking about when we are talking about Ebola. Preparedness is not just having tents, having ambulances, PPEs, some fever scanning machine. All are very important, yes, but preparedness is asking ourselves, do we have clear laws that protect Kenyans? The whole agreement between the Kenyan government and the US government is our framework, our legal framework. Does it prioritize Kenyans? And does it obligate the government to comply with its constitutional mandate of protecting Kenyans? Is there clear communication being provided to Kenyans? Is their right to access information that is exclusively in the possession of government, is that being adhered to by the government of Kenya? Do we have trained healthcare workers? We've seen statements to the US government, to their, is it Senate, Congress, challenging the level of training that healthcare workers in Kenya have, and saying that they have better training, they have better infrastructure, they want their people there, not here. So do we even have the trained personnel? Do we have community involvement? Are the voices of our people being heard? So when we are talking about preparedness, let's not just look at it from the medical perspective. And this is where we then, get into murky grounds. The court is saying that the government of Kenya has some questions to answer, some information to provide before it can proceed with the plans that it has made. But then we have to look at what the public is interpreting the response by government to be. If the public sees the government is acting in a manner that is disregarding court oversight, then that's a very dangerous trend that we are setting. That's a very slippery slope that we are going into. A democratic country does not compel the government to agree with court decisions. Yes, the government can disagree and say, this is our mandate as government, and we have an obligation, and this is how we are performing it. But then it must disagree with the court in a manner that it can challenge it using lawful means. It can appeal a court decision. It can seek review. It feels the court or the citizens who've taken it to court are being unreasonable. But then we must not allow, any type of actions by the government that create a perception among the population that they don't want to be held accountable. That is part of a public health response. We need the citizens to trust the process, to trust the government, to accept the interventions that are being provided. All that is part of preparing.
Okay.
Yeah.
I think I absolutely agree that the extent to which the information is being dispelled is a big problem. And I think that's where the distrust between the public and the institutions that are in charge of kind of disseminating this information, like that gap, that's where it's coming from. So what are the health communication gaps we are facing? And I think I would like to hear from both of you, considering you told me before, you as scientists, you're always communicating with other scientists.
Yes,
Like, what are the health communication gaps happening right now that are very visible, at least on your end, that are causing such a rift between the preparedness that needs to be set up and what the public needs to know?
Okay, so I could try, and then Caroline can add more. Communication during an epidemic is very important because it sets the tone through which the public will respond. And whenever there's an intervention done by government in a particular area, set up isolation center, it must involve the community. And so you must distill the information that you have to a way that the common man can understand. So one thing that the government, I can say, has not done very well, I listened to CS Duale in Parliament and also the parliamentarians, and they alluded to what was contained in the agreement. And it was very interesting. First of all, we know that the American government has been cooperating with Kenya for many years. HIV/AIDS, they have supported the country for many years. In malaria, we have got many centers here that are equipped by the US government to support our healthcare system. So one thing that I think the government should do better is invest more in healthcare communication. For example, very briefly, the agreement contains a few items, if I may just list them very fast.
Yes.
So the cooperation agreement between the US government and Kenya talks about the US government supporting the Kenya government in surveillance. Surveillance of disease outbreaks. Okay, this costs money and it needs resources. Okay, and it needs expertise. Okay, so the US government is supporting the Kenya government in that. It's also supporting the Kenya government in laboratory equipment and support. You've heard of laboratory levels of biosafety of laboratories. Okay, and biosafety lab level 4 is the one that is mandated to deal with Ebola-like conditions, isn't it? We've got one in Gabon and one in South Africa. In Kenya, we've got a level 3, which is pretty high at other countries, but it's through support of the US government and other partners. In the agreement, again, there's technical guidance. So they have got expertise in dealing with these viruses, so they will train our personnel. They'll take them for training and support them. Again, there's logistics. How do you transport some of this equipment, or how do you transport these specimens? Okay, so the US government is supporting in that. Then an important one is health risk communication. I would really love to see this manifesting, because till now, the health risk communication of Ebola is pretty minimal. Okay, so our government needs to invest in that. And then the final area in the agreement is partner resource mobilization. This is about money, right? So we know we have got other priorities, health priorities in the country. Now, Ebola is emerging, so for us to move resources immediately from some other health priority to Ebola is not likely. So you find that some of these partners will partner financially to support the country. So I just thought I'll mention this because I think the government can do better in communicating what is in the agreement. What is not in the agreement is setting up of that center in Laikipia.
Okay. Yeah. Okay. Before you come in, I just want us to take a listen to the Secretary of State, that is Mark Rubio, United States. He had something quite interesting, which has gone viral among Kenyans and the social media platforms. If we can take a listen to Rubio and then come to Caroline with a follow-up question in regard to what Mark is stating. Take a listen. Mark, or
something else that I know is concerning people, because it's on the news, is Ebola. Our number one obligation, we're involved in foreign policy, but even our foreign policy, the number one priority of our foreign policy is to protect the American people. We cannot and will not allow any cases of Ebola to enter the United States. And so the State Department and other agencies represented here, the Centers for Disease Control, HHS, others, are working very, very hard to contain this crisis to the countries where it's currently located, particularly the Democratic Republic of the Congo. And so we've surged assistance to make sure that is being contained there. And obviously, multiple agencies involved here are also very involved in tracking people, just to make sure that nobody comes into this country that has Ebola and creates a problem for us. And we feel like we've got good efforts in place to do that, and Americans should feel assured that the President and his administration is doing everything we can to protect them on that front.
Right, there you have it. Marco Rubio, Secretary of State, United States of America, speaking to the efforts of the American government to put Ebola at bay. My question to you, Caroline, picking cue from what Dr. Nelson has said, all the investments, all the money, does it then warrant Kenya to be a safe haven?
A safe haven for?
Placing Ebola at bay from the borders of America.
Okay, all right.
Why Kenya? Why not Uganda? Why not Congo? Why Kenya?
Well, I think Nelson answered that. We are the ones with an agreement right now. The Ugandans don't have such an agreement with America. That's one thing. And let me tell you about Kenyans, tukombele sana. I mean, we run for things even before I show what they are. We run for them and we do all manner and kind of things. So that is why it made sense for them to come here. Now, what that Secretary of State said is true. That's what we should be saying for ourselves, that we also don't want Ebola in our country. We also don't want our citizens to be under this risk of Ebola because we don't have it. So a fair ethical test is to ask, if we were to decide to have a center in America for Ebola, so that people can go there rather than come here, what will the Americans say? And you can be sure he's already said it. They will not stand for it. They will not allow an index patient to be flown into their country in the name of whatever, quarantine. So that's good for them. So us here in Kenya, we can also take that point of view. But guess what? We are much closer to Ebola than the Americans. For goodness sake, up to this day, I don't know how come we have not had it in our country. We are so close to it. So it would be foolhardy, my father likes that word, foolhardy of us not to be prepared. Now, what has that got to do with this facility? For me, I'm just with Melba with this. Look, you have to be transparent and you have to be accountable. You really have to be transparent and accountable. You can't give us half stories about what is going to happen. And the fact of the matter is, when something goes wrong, what are they going to do? I think that's if they can answer that question, then I think I'd be better. Even with the health communication, I'd feel a bit better. Are they just going to say, oh, that didn't work, sorry, and just take off? Is there going to be any kind of compensation? Because something could go wrong, and it's a fair question. If something was to go wrong and Ebola was to escape, I mean, how ridiculous would we have been as a Kenyan country to allow a problem that we didn't have to become our problem because we are being what? That we are cooperating internationally? Doesn't seem to make sense. So, but if they can answer these questions, and that's what health communication you are talking about, really they should just have this kind of course, and that person should be speaking into the ear of our politicians, because our politicians have a totally different agenda. Mm-hmm. Please don't forget, if they get Ebola, they will be the first ones to be flown somewhere. Mm. So we're just talking about the ordinary one, Chico. Those of us on this table, if we were to get Ebola, what would happen to us? Yes. Yeah. And it would be so annoying to get Ebola because somebody flew it in.
Wakili, then Caroline poses quite a very integral question into this conversation. What if something goes wrong? And, Kenya's number one foreign priority is protecting and advancing Kenya's national interest. What happens if something goes wrong?
I was just going to react and say, if they got Ebola, they wouldn't even go to Laikipia, where they want to set the quarantine facilities. They'd probably fly out somewhere. I think, before I answer your question, let me just say that where I think we are getting it wrong is that we are not answering, we're not communicating in response to the concerns that Kenyans have. We are answering our own questions. The main concerns that Kenya has and Kenyans are asking, is America exporting risk to Kenya? Now, if you look at all the communication that has come out from the CS, from the PSs, there's no response to that question. The biggest concern, and this is a legitimate concern that needs to be interrogated and doesn't need to be brushed off, is America exporting risk to Kenya? Are we at risk? Are we protected? Are our interests safeguarded? We know that, fear spreads faster than the disease. So where citizens are not given clear information about the nature of this collaboration, this cooperation, rumors will fill the gap. And surely we've seen that rumors have filled the gap. So in terms of Kenya, we are not only, the concern that the CS addressed was the issue of public participation. But when Kenyans are demanding for accountability, it's not just about public participation. If you look at the rights that are provided under the Constitution, Kenyans are actually demanding access to information under Article 35. Kenyans are demanding transparency and accountability as enshrined in Article 10. Kenyans are asking for fair administrative action under Article 47. So it's not just about one issue of public participation. There is the rule of law. So the Constitution is not suspended when we are responding to a public health, emergency. We have to test the validity and the strength of our constitutional rights as Kenyans during emergency situations. So the government has constitutional obligations, the government has legal obligations, and hopefully moral obligations to the citizens of Kenya to actually provide them with communication that responds to the fears that we have. Yeah.
Yeah, Justin?
I think the entire risk factor lying on the country, on us, as all three of you have pointed out, is it's a big concern for Kenyans. Yeah. So I would like us, at least at this moment, to be able to just paint, at least for the two bioethicists in the room, like if you could kindly paint, even Melba, if you could kindly paint, how do I say this? What's like the best case scenario for preparedness? What does that look like? And what's the worst case scenario? Even if we have a preparedness, considering as having on record we've not had an index patient in the country, what's the worst case scenario? What could that look like, especially with the strain that is currently very prevalent, the Bundibugyo strain? What's the best case scenario and what's the worst case scenario regarding preparedness?
Okay, I could try that. It's difficult to say the worst case scenario in epidemics because the worst case scenario is probably we all get wiped out and we don't have any form of response, or the response comes too late. So I'll rather comment on the best case scenario. It is established that in managing epidemics, you manage the epidemic at the site of the epidemic. Science has proven that, and that's a principle that has been established, okay? Because the moment you transport one patient, you multiply the risk in ways that you may not be able to control. I told you of the case in Nigeria where somebody sneaked out and it affected 20, okay? I would say for me, if I was fortunate enough to be an advisor in high places, is in Africa, isn't it, right? Is to establish that quarantine and isolation center right where the epidemic is happening. That is the best case scenario, I would say. Transporting it across a different country many miles away is too risky a venture. Yeah, that's it.
Okay, Caroline,
right.
could you...
Because we need to wrap it up. Maybe just a follow-up question as you respond to Justine's question. I mean, in previous events, we have had Ebola outbreak, right? Even close here, Congo, 2018 to 2020. Then, as a country, how did we, respond to this particular emergency or epidemic, and what can we copy paste from then to the times we're living right now?
Yeah, okay, so of course all our border patrols, all our border hospitals, or even the border officials themselves were put on high alert. And everybody was told to understand what the symptoms are. So you would come in and they'd check for specific things, including temperature and what have you. So at the border, that was one thing that they did really, really carefully. And that's okay, because people are coming in by bus, people are flying in. So with every port of entry was on high alert, including JKIA. So you've heard of this thing called port, at the airports, they're called what? Port Health
Authorities.
Port Authority. Yeah, sometimes we think we don't know what they are there for. That is what they are there for. So in any place where somebody could come into the country, we have people on high alert to be able to at least detect it. Because the minute you detect it, then you can put people in a quarantine and they will not infect other people. Because eventually, if the virus doesn't live outside a human body, it has to be inside a human body. So if you can stop it from moving from one body to another body, it will be contained. So that's what usually happens. Then, as the public, now that's the big question. What should we be told as the public? And you have to be careful when you're telling the public, because you can create a lot of panic in the public. There was a grandmother in Kitui who was calling me and saying, tutakufa leo, nimesikia Ebola iko kwa inchi. So the way to communicate that, you have to do it in such a way that you do not, you give information without killing people with fear. Yeah, we don't want to die of fear before we die of Ebola. Yes. But Ebola in itself is like, if COVID came and went, it would probably come and go. But as I said before, the way we react to it is what is going to make the difference. And if we are level-headed and we do what we need to do, we can contain it. But if we are not level-headed, we will now spread it properly. Yeah. Thank you.
I hear you. Well, just as you said about fear, and it's quite something interesting. And I want to loop in Wakili, and pick your final thoughts on this particular conversation. We need to wrap up. 60 minutes into this conversation
has gone.
Yeah, and my director is killing me. He's like, we need to wrap up. But starting with you, Wakili, can there be any correlations between, Kenya, we experienced the pandemic, the COVID-19 pandemic. you being fair and accurate, are there things that as a country, again, we can borrow from to respond to this Ebola issue?
Well, COVID taught us a lot of things, which has been what we are advocating for as actors in the public health space. COVID taught us, especially from a legal perspective and a human rights perspective, that public measures will fail when they are not imposed in an environment of trust. So if we put public health measures where the community does not have trust in the system, in the mechanisms, in the interventions, they are going to fail. The other thing that COVID taught us, that if you coerce people, if you force people, you threaten people into complying with public health measures, it doesn't manage the disease. In fact, it creates a lot of distrust and disconnect among the communities, and a lot of the time it creates a lot of vulnerability. It's the poorer people who suffer from coercive interventions. That's what COVID showed us. Finally, COVID showed us that when we have emergency powers and when we create laws and guidelines, restrictions, when we have such powers during public emergencies, they can be subject to abuse. They can be subject to excessive force and discriminatory appliance. So there needs to be oversight. The court's oversight is important. So when we put those three things together, then a good public health response means, one, there is fairness and transparency in the types of arrangements that we are making. Two, there is benefits and there is protection that is being communicated to Kenyans. And three, communities and citizens are valued as really key stakeholders and really critical components in a public health response. If we carry those lessons into what we are doing now, I think we'll have a much better response because COVID prepared us.
Yeah.
Yes. My last word.
Yes.
Okay. So for me, the ethical problem is not preparedness, truly. That's not the problem. I mean, we've gone through so many other epidemics and we have been prepared. And Kenyans should prepare for Ebola. So I would not like people to go away thinking that we should not prepare for it. We should. I think the ethical problem is whether this arrangement is transparent. Is it transparent? Is it fair? And is it lawful? Over and above everything, it has to be lawful. For somebody to say that the Public Health Act allows us to have quarantine, and then the quarantine is not for Kenyans, the quarantine is for citizens of another nation, it does not make sense. It does not make sense. That is not fair. You know, is it protective of Kenyans? And most of all, is it respectful of public trust? In a public health emergency, trust is not a luxury. It really is not a luxury. It is key to whether it is going to work or not. I think I'll end with that.
Yeah. Dr. Nelson?
Okay, thank you. The discussion has been quite interesting. So I will say, well, in the legal circles, there's something called stakeholder engagement. But in the ethics world, we call that community involvement. Now, the community involvement in an emergency response is not as important as if there's no emergency. Right now in Kenya, we don't have the Ebola emergency. So I will say that it's time that maybe the government and the politicians and the administration can use this time to engage the community, to demystify issues and communicate, and therefore establish a center after having discussed with the stakeholders. So right now, forcing it down the throats creates distrust. And that's my parting shot.
Okay. Thank you so much. Thank you so much. We did pose some questions to Kenyans just to be part of this conversation. One of the questions that we posed to them is, you've heard the facts about the Ebola facility in Kenya. What should happen next? and 87% are saying shut it down. Shut it down. 4% parliamentary inquiry, 4% negotiate Kenya control, and 4% continue as it is. It's fine. Well, those are Kenyans. Just another, let me get to one more. Yes, another question we did pose to Kenyans. Kenya is hosting a foreign-funded Ebola facility. Where do you stand? Do you want to take a guess? How many said it threatens Kenya's sovereignty?
100%.
70%. And then 0% are it's necessary. 20% they do say benefits outweigh the risk. 10% we need more transparency first. Yeah, that is what Kenyans are sharing. It is a poll that we shared with them and to pick their mind on this particular discussion that we were having today. Justin, we need to come to a close on this conversation. Yeah, what say you? Do you think there are some correlations between, Ebola and COVID-19? You are wise. I know you can share something.
Because I didn't study. I did not, but I can borrow the Bioethicist cap from the three of them. Yeah. The thing I think we are supposed to learn continuously, especially given the nature of these diseases, is people are very easy to misinform, considering just how much access to information we have now. And as a person who is chronically online, maybe you guys are better than me, you see the conversations Kenyans are having, and it's very hard to not feel like it's doomsday, like we're gonna die tomorrow. Sometimes that's what it feels like. And also, just to echo what you've said, the public has to trust the information that's coming to them. And if there's a deficit in that information, if there's a deficit in the trust within the system, and also how they are talked to. If you talk down to Kenyans and become combative and defensive, the chances of you getting anywhere with a very important message is going to be minimal. So just to add on, I think it's very important, just like we learned with COVID, is that you put the information at the forefront and also build a trust system with Kenyans. Don't try and talk down to them and tell them, Nyamaza, you don't know anything. Najua kona sha or something. Don't talk to people as if they don't have stake in the game. They have skin in the game. It's important to them, so it has to feel like they're being prioritized too. Yeah. So without that, goodbye. I'm baffled. Yeah. This is you. Yes. Checky, I'm wise. You explain things badly, but anyway, there's a saying that goes, fear spreads, faster than virus. Is it so? It is true. Dr. Nelson, yeah? Yes. Anyway, we leave it at that. Thank you so much, Dr. Nelson Malenya, a bioethicist and a protocol reviewer. Thank you so much, Caroline Katindi, also a bioethicist, lecturer and research ethics reviewer. And from the land of coldness, baridi, and heho. Thank you so much, Wakili Melba Katindi, an advocate of the High Court, for making time and just having this conversation to the benefit of our viewers and our listeners from wherever they are getting these, catching this particular episode of The Big Picture. And just after this, we will be having Justine doing her thing, explaining things badly. Could you like a snippet of what we are to expect? Just a little bit. This past week, we saw an urban planner who's stashing cash in his home. Yeah. FIFA World Cup 2026 is going to be starting on 11th June. So for the people when you're menyimwa visa, poleni sana. Maybe you're in an area with a quarantine facility for Ebola, so they were just taking precautions. And then we also have the housing levy could be securitized. Yes. So that's a proposal that's out there, so maybe all right. Your paycheck is at risk. Yeah. Paycheck. Again. Again. That is just still, you should be doing the explaining it all after we're done here. My name is Moige William. Much appreciative for your invaluable company. Each and every Monday you've been making time and being part of this particular conversation and program, The Big Picture Podcast. Oh, before I forget, we had promised you that we'll be coming to the town near you, to your county, and
I'm excited that our community manager has been working on something together with the whole African Censored team, and we could be coming to a town near you within Nairobi County or Machakos County, and afterwards we will be coming to the coastal city. Watu wa pwani, tuasija, mtusubiri. We'll be bringing the conversation closer to you. So please do follow us on all our social media platforms so that you can know what you're planning next for you. We could be in your county coming next week or the week after this. So keep it African Censored. Follow us on all our social media platforms and you will be informed appropriately. My name is Mwege William. Do enjoy the rest of your week. Goodbye for now.
Goodbye.
Home is where the bank is, especially for Nairobi City County's Chief Officer in charge of Urban Development and Planning, Patrick Analo, who was caught with 65.3 million shillings in his house. An initial report had stated that 250 million was found in his premises, but EACC clarified that there was only 65.3 million. Kenyans have dealt with so much inflation that they are starting to hallucinate it in the expansion of theft. Or maybe the EACC is just really bad at counting. Cash is king, and he used it to build a throne of supermarket couture bags full of cash all around his house. For someone with a master's in urban planning, he hasn't yet mastered the art of stashing cash away. He had the money stored in different currencies from dollars to euros and some Kenyan shillings because no one knows the day or the hour that 129 Kenyan shilling hold against the dollar will dip. He also diversified his accounting system away from his in-house paper bag ATMs, storing some of that loot in the boot of his car. Matatu users, that could never be you. The video shows an exterior exploration of his color collage-inspired residence, which kind of mirrors the headache of how this city feels. People online were really judging his house, but what if he's just using the exterior walls of his house as paint patches to advise the Kuyo landlord community? Have you thought about that? Plus, his house is in Syokimau. Maybe the house colors are just paying respect to the area's ancestral heritage. Nairobi Governor Johnson Dimple Rep Sakaja suspended him pending investigation. He also said that Patrick will not be allowed back into the county offices, not given any access to official documents, or even into the pineapple under the sea of Nairobi's planning problems until the investigation is concluded. The governor announced a sweeping overhaul of the county's development system, saying it will now include professionals only from key sectors of architecture, sewerage, and engineers, unlike before where it was just more of a goon in time saves cash in his house. Mr. Analo's bribery fort is being brought down during a time when buildings have fallen, such as the recent one in South Sea in January, which left at least 4 people dead. Hopefully, those victims will get justice and Nairobi's housing is better planned and protected. Speaking of housing, a new proposal just dropped.
Now, a bold fiscal maneuver could lock the controversial housing levy into Kenyan payslips for generations. A new parliamentary report reveals that the State Department for Housing plans to plug a massive 118 billion shilling budget deficit by securitizing the housing levy to borrow 100 billion shillings from development partners.
Do you Kenyans take the housing levy to be your lawfully securitized cut in sickness and in paycheck health until your paycheck demise does you part? The payroll trauma is on a roll as GOK is proposing to securitize the housing levy in a bid to borrow more money. For all of you who don't speak finance bro jargonian, securitization is just a fancy term for we already spent the cash that we haven't robbed from you yet. The move is meant to plug a budget deficit of 118 billion Kenyan shillings by securitizing the levy to borrow 100 billion Kenyan shillings from development partners. GOK's Omba Omba stage is a permanent fixture of the economic plan because development partners include global funders, private developers and contractors, and financial institutions. And remember, securities can always be resold to other investors. It's like a never-ending party with your money. These brilliant economic advisors looked at that 1.5% payslip deduction and thought, The sustainability stream of paycheck tiers is so beautiful. So we are glad we can monetize it. It has worked so far with the road maintenance levy that even the prices of fuel are starting to look like a struggling KCPE candidate improving after mock exams. Sidebar, EPRA is reworking the formula of how fuel is priced. So for anyone who is out there waiting for these numbers to come down, there's no REMA here. If this housing levy is securitized, it means whether this government goes or not, this levy will still be committed to you than your ex ever was. Seasons will change, Gikomba might get skyscraper markets, but that deduction is eternal, like casinos pop out in hell. So if you're still lucky to have a paycheck, hold it tight before GOK takes out the larger paycheck scissors and gives it a forever loaned out mohawk. Elsewhere, KWS has announced plans of moving the animals from the animal orphanage's current location to a facility that is 10 times bigger right next to Bomas of Kenya.
Kenya Wildlife Service has announced plans to relocate the animal orphanage as part of a new project estimated to cost up to 4 billion shillings. The new orphanage will be constructed within the national park.
It's about time those orphans had good things going for them. It's like moving from a bedsitter in Pipeline to a 3-bedroom in Runda. At least now they'll be so far back in their big cages that people won't even be able to tell that they're starving. The project will cost up to 4 billion Kenyan shillings, which is a small sacrifice to give up in daily corruption losses. Plus, the new Bomas of Kenya will have hotels, making it the first facility in the world where you can trophy hunt orphaned animals straight from your hotel window. Once the new facility is built and all the animals have been moved, the current facility will be demolished and turned back into its natural ecosystem. And you know it's in Langata, so we all know that's just going to be a middle-class apartment with water issues. On to other issues aboard, passengers on Frontier Airlines had to restrain a man who tried to open an emergency exit door and jump from the plane mid-flight. Skydivers are getting too comfortable being airborne. Maybe he boarded Frontier Airlines because he believed that they would be at the forefront of supporting his personal takeoff ambitions. He was ready to release his inhibitions, putting the entire cabin at risk, but sometimes you have to let the voices in your head win. It's difficult to know the motives of the unhinged, but he probably wanted to taste the Superman altitude with that Homelander attitude to see what happens. He was restrained by fellow passengers, including one who's an MMA fighter. Move aside, doctors, you are not the only important high-altitude professionals anymore. You are at least now number 3 after pilots. So to all MMA fighters, at times you train to beat up opponents in the ring while having no health care, but the true test of your mastery is a guillotine chokehold to save 200 other people mid-flight. Lastly, FIFA World Cup 2026 kicks off on 11th June, co-hosted by neighbors in hate, that is Mexico, Canada, and the USA. Fans across the world are already hyped, with many being welcomed by the cultures of most of these countries. In Mexico, teams were received by mariachi bands. In the USA, they assigned each player an ICE immigration officer while handing out a bulletproof vest for a small dynamic fee. And in Canada, they had Drake just handing out giant ice cubes at the airport. This World Cup is the biggest one ever. It has moved on from the tournament having 32 teams to now 48 teams, 12 groups of 4, and 2 hydration breaks because Mother Earth is on a real hot girl summer change. The tournament will also take 39 days, up from 32 days, to make room for all the ads that US companies need to play. Mexico and Canada are trying to hold their end of the festivity bargain as they hold 13 matches each, while USA is committed to the red, white, and blue marks of loyalty before allowing entry while they hold 78 matches. Iranian and African journalists have already been denied necessary visas to move across countries, especially into the USA, meaning if their team goes for a match in Canada or Mexico, they should just start a new life there and not return to the States. Iranian players are only allowed entry to play but can't stay in the USA, meaning extra time on the pitch could mean extra time with the ice. And African fans have been encouraged to just build a wall around their minds to prevent them from even thinking about flying to watch any matches live. For those attending, tickets are going for as much as $1,100, which is rent in Oklahoma or a small portion of land in Kamulu. And that's without accommodation or airfare. Good luck to all you football fans out there. May the FIFA Peace Prize be with you.